So my name is Nicolene Schiess. I'm a technical officer in the WHO Brain Health Unit. And I'm very happy to be here again for the Global Brain Health Clinical Exchange platform. Just as way of a bit of history, the idea and the implementation for these sessions began in the early stages of the COVID pandemic. And at that time, the Brain Health Unit, which was very new, which had just been formed in the WHO, put together a neurology and COVID-19 global forum in order to convene and generate discussion and knowledge exchange, particularly about COVID at that time. But what it also did is that it brought together a very large number of fantastic neurologists and neuroscientists who were interested in helping and promoting the education of neurology and neurological conditions internationally, particularly in low and middle income countries. And so this is where the collaboration started, and we've come a long way since that time, and very happy to be here to support this, and very excited to hear more about the show today, Sherry. Thank you.
Thank you so much, Nicolene, and many thanks to the WHO. So without further ado, I am honored to introduce our speaker today, Dr. Ayush Batra. Dr. Batra is an assistant professor at Northwestern University Feinberg School of Medicine. And he is trained in neurology and specializes in neurocritical care, and also a fantastic physician scientist who investigates various different mechanisms of brain injury, particularly with regards to interaction with immune system and immune dysfunction. And he's prepared a wonderful case to share with us today. And so without further ado, Dr. Batra, please take us away.
Thank you so much, Sherry, for that introduction. So good morning, afternoon, evening, everybody. I'm going to get started with sharing my screen. Just please let me know if you can see it. Sherry, everything looks okay? Great. So again, thank you again to the Global Health Network and the WHO for arranging these sessions, and looking forward to sharing an interesting case that we've experienced here in Chicago relevant to the COVID-19 pandemic. And thanks again, Sherry, for that wonderful introduction. So I'll just go ahead and jump right in. I have no relevant financial disclosures, anything discussing here. There's no off-label treatments or anything like that. So COVID-19. The past 2.5 years, this is a word that is probably more known across the world now than ever was before. And, you know, at the start of the pandemic in March 2020, as neurologists, we started becoming alarmed when we started seeing reports of neurologic manifestations of COVID-19, with the first reports coming from Wuhan, China. And, you know, subsequent reports from the ALBA COVID registry in Spain, and then even alarming reports in the US, though very limited cases of, you know, large vessel occlusion in acute stroke in young COVID-19 patients really became concerning for neurologists, neurointensivists across the country and world. And that led to kind of our early work evaluating the frequency of neurologic manifestations in COVID-19 from that first summer. So this dramatic, you know, increased incidence of neurologic disease across the country at the onset of a pandemic became very relevant to all neurologists of why we should be, you know, interested and be investigating COVID-19. So, you know, a brief review of the pathogenesis of SARS-CoV-2, the virus responsible for COVID-19. It's an RNA virus. You know, coronaviruses have been around for over a century, as far as we know. What's unique about SARS-CoV-2 is the spike protein, which again, everybody has heard so much about over the past 2 years. But this spike protein binds to ACE2, a kind of widely diffusely expressed cell membrane receptor across various cell types and various organs, internalized in the cell. And, you know, once the RNA is released into the cell, the RNA can either then be transcribed and translated into proteins, or by, you know, taking over host machinery, or bind with the replication complex and release more RNA. And this cascade of events then leads to more viron production and subsequent release. And you get a cascading effect that multiplies, and such as the onset of a, you know, RNA-mediated virus. What's unique about coronavirus is, again, this high binding affinity of that spike protein and the widely expressed ACE2 expression, which here you see some immunohistochemistry kind of confirming the endothelial and epithelial staining across lung tissue. So this widely expressed receptor across multiple organs makes it the perfect perfect virus to target multiple organ systems. And again, mutations of the surface protein can lead to different strains. And I don't need to stress how much we've learned about different strains through this pandemic just in the past 2 years. So that's just kind of a brief background or primer on SARS-CoV-2 and COVID-19. And let's jump directly into the clinical case I wanted to share with you today. So we'll start with, so JC is, and this has been anonymized for patient confidentiality, but JC is a 37-year-old man, history of hypertension, obesity, anxiety, and a tobacco use disorder, who was initially presenting in March with 2 weeks, and this is March of 2020, with 2 weeks of fever, chills, shortness of breath, and diarrhea. He developed a worsening fever and increasing fatigue and was admitted to a local community hospital in the suburbs of Chicago, Illinois, with a positive SARS-CoV-2 PCR swab. Now, if you recall, early in the pandemic, particularly March of 2020, the ability to test in the US was particularly challenging. So it was really limited, and clinicians had to make pretty clear decisions on which patients would be warranting testing and which would not. But here we have a young gentleman with multiple medical comorbidities who certainly warranted testing at that time when available. Unfortunately, his condition deteriorated pretty rapidly. Within 24 hours of entering the hospital, he developed severe encephalopathy, hypotension, acute hypoxemic respiratory failure, which prompted his intubation, requiring a ventilator. And at that time, many community hospitals in our setting just didn't have the capacity to take care of so many ventilated patients, and the rapid progression of the disease in these patients prompted transfer. So this patient was transferred from a suburban hospital to our tertiary care center in Chicago at Northwestern Memorial Hospital. On arrival, when he was transferred, he went directly to the medical intensive care units, and his ventilator settings, which I'll review shortly, he was on 100% FiO2, or fractional percent of inhaled oxygen, which is very high, the highest it can be. And his PEEP was 18 on ACV ventilation mode. And that means, his positive end expiratory pressure, the pressure required to maintain his alveoli to participate in gas exchange and remain open, was 18. And for reference, the normal physiologic level, somewhere between 3 and 5, so very high ventilator settings on a controlled ventilation mode. He was started on empiric antibiotics with ceftriaxone and azithromycin. At that time, again, there was a lot of concern for bacterial superinfection, and initially given a dose of methylprednisolone. Bronchoscopy was performed, which did not reveal any evidence of frank mucus plugging. There were minimal secretions, with such high oxygenation requirements. That was kind of early on, that was done pretty regularly at our center. And he was able to undergo a CT scan of the chest, which was notable for multiple segmental pulmonary emboli and focal consolidation. And I have some representative images from his CT chest, which is quite striking. For an otherwise, well, I don't want to say healthy, but otherwise, fully functioning 37-year-old guy who didn't have any significant medical disability at that time. He went on to develop a severe acute respiratory distress syndrome, or ARDS, which we'll also talk a little further about, with hypotension, shock, and renal failure. His ARDS was so severe that he required paralysis, necessitating heavy sedation and proning. And numerous specialists began to be involved in his care, including, of course, our infectious disease colleagues, our nephrology colleagues, the pulmonology colleagues, and neurology. So I'll take this time just to pause for a second. So question for the audience, and feel free to just respond as you can. So what percentage of hospitalized COVID-19 patients presented with or developed neurologic manifestations during the onset of the COVID-19 pandemic? 0 to 5%, 10 to 20%, 30 to 60%, 60 to 80%, or 90 to 100%. And we'll give you guys a few minutes just to answer that whole question. A minute or two. See, don't feel shy, jump in. There may be multiple right answers. Okay, Adam, I think maybe we can share the poll results. We have enough responses. Great, so as many of you may have already seen, so the vast majority are are in the 10 to 20, 30 to 60% range, and 60 to 80. Well, depending on the literature you look at, it was either 30 to 60% or 60 to 80%. And I think that early literature reporting on the neurologic manifestations of COVID-19 somewhat confounded by, were the neurologic symptoms present at the onset? Were neurologic symptoms present during the hospitalization, or did they develop as a consequence of the hospitalization? So pretty wide range, but needless to say, 30 to 80% a wide range, but certainly relevance for neurology and neurocritical care providers. So our consultation service at Northwestern Memorial began early in mid-March to evaluating and seeing these patients as we traditionally do in our structure. What was unique and necessary for the neurocritical care evaluation of these patients is a multidisciplinary team involvement, including our collaboration with our medical ICU colleagues, our pharmacists, including our psychiatrists as well, to develop a standardized approach to assessing these patients because they had such severe sedation and analgesia challenges that it really confounded your neurologic exam. So this uniform approach to sedation and analgesia really allowed us to identify those patients who required additional neurologic workup and let us kind of appropriately triage limited resources in that time period. During this period, when we were kind of assessing the sedation and analgesia needs, we also recognized through this process the various phases that patients were going through, one from the initial admission through their progression in the hospital. This early active phase of disease, the most acute phase where they developed sudden, rapidly progressing ARDS, saw a rise in inflammatory markers, and these patients required very high oxygenation and ventilation requirements. After that first week or two, some of them were able to transition into more of a transition phase, as we termed it, where we started to see this inflammatory markers stabilize, ventilator needs no longer increasing, and potentially start to allow for sedation holidays where we'd stop sedation to really perform some neurologic assessments. And then finally, they developed the convalescent phase where the hypoxia would improve. We'd see downtrending of their inflammatory markers. We'd be able to wean them off sedatives altogether. And here's where we had kind of an unconfounded neurologic exam for these patients. Interestingly, right around that time in March, we saw a lot of literature start coming out on the viral response and kinetics of COVID-19 relative to the SARS-CoV-2 virus. And we saw this early viral phase was associated with very mild symptoms, but then rapidly after, this inflammatory response would progress. In stage 2 and stage 3, we'd see hyperinflammation. So this, natural pathogenesis of the virus kind of linked very clearly with the critical care clinical observations we saw. And as neurologists and neurointensivists, this became relevant to us because we had to try to identify the appropriate time to address patients and see when was pathologic, abnormalities needed to be pursued further. So jumping back to our case with JC, these traditional laboratory markers of inflammation that are used non-specifically became the standard in our hospital system. And just kind of trending out JC's, these broad inflammatory markers, we can see kind of his white blood cell count would peak early in the phase at admission in week 1, and then start to trend down over by week 3, week 4. We would use the C-reactive protein, an acute inflammatory marker and biomarker, which we would see trend up in the first week or not. Procalcitonin, which was useful in helping us kind of evaluate for superimposed bacterial infection, though not incredibly sensitive, the specificity was helpful. And then increases in D-dimer and ferritin, other acute phase reactants, and D-dimer, a degradation product of fibrin, kind of suggesting increased coagulopathy and coagulation. We would see this trend kind of in a later phase. So these markers were kind of useful clinically. What exactly to do with them and how to trend them, I think still there was a lot of debate and controversy even to this date on how we should use them, but it was helpful early on when we didn't know the trajectory of our patients. Our evaluation would come in somewhere between, that second phase or the convalescent phase. And this is the time where our medical intensive colleagues would really request our assistance and where we felt we could contribute to the care of the patient. So these patients, after weeks of high sedation, proning, paralysis, now they ask us for a neurologic assessment and kind of what can go wrong and what can go right. So we were consulted for a wide range of patients. Agitation was the most common issue, and agitation on the delirium encephalopathy spectrum of disease. These patients have their sedation held for 24, 48 hours, even longer. And in JC's case, he had no eye opening to voice or opening to any noxious stimuli. He did not regard, did not track, did not follow any commands. His brainstem assessment is what we become limited to, and kind of you can see the state of the patient would be, typical patients like JC. perform pupillary reflexes, corneal reflexes, his oculocephalic reflex was intact, his gag reflex was intact, and he had a strong cough, but no withdrawal in any limbs. So this was fairly typical of many of the patients we would see, a comatose examination after someone who's been in the hospital 3-4 weeks. So what would we do next in this setting as neurologists and neurointensivists? So this leads me to my next full question. Of the diagnostic tests that we are so fortunate to have available, and at that time, even those were limited, would you perform a non-contrast head CT with this examination, electroencephalogram, lumbar puncture, MRI of the brain, or a cerebral angiogram? And we can open up this poll in a few seconds. And I think, Adam, that's probably, maybe give a couple more seconds for more participants to jump in with what they would do next. All right, so looks like a large percent, interesting, with large percent would do an MRI of the brain, electroencephalogram and CT scan, a lumbar puncture pretty low on this list, and nobody would do a cerebral angiogram. More or less, I think any choice is reasonable. Maybe cerebral angiogram, not as reasonable. I mean, we're not talking about a invasive cerebral angiogram in this case, but the reality is I think any choice would be reasonable depending on your specific environment and setting and what test is readily available. I can tell you in our experience, we had initially done a lot of non-contrast head CTs for these patients, but now imagine you have patients on very high ventilator requirements, their infectious disease exposure, so their contact precautions, and transporting these patients to the CT scanner that is often not on the same floor is quite a process and it's very labor intensive. So, after performing numerous CT scans in many similar cases, our system, we actually started to go straight to MRI. And that's what we did for JC's case, just because we saw very little on CT scans initially. So in JC's case, I'm just going to quickly go through some of the MR findings. So he had, an MRI of the brain. This is done roughly about 4 weeks into his course. The FLAIR sequence, or fluid attenuated inversion and recovery sequence, kind of lets us look at abnormalities in the gray and white matter and CSF here. If I can convince you, there may be some subtle hyperintensities in the bilateral mesial temporal lobes, insular cortex, non-specific white matter hyperintensity here in a 37-year-old gentleman. So just to keep in mind. And pre and post contrast scans, we did see evidence in JC of some, punctate leptomeningeal enhancement. I mean, these are subtle findings. It can be difficult to call and what's pathologic and what's not. Certainly, this little leptomeningeal enhancement can't account for his current neurologic examination alone. And our diffusion weighted sequencing, we see kind of a punctate region of diffusion restriction, which could suggest either an ischemic stroke, or sometimes we see abscesses like that. His cerebrospinal fluid evaluation, so we again progressed to do a series of tests, was abnormal. And we see an elevation in his protein count. His IgG index was elevated, but the opening pressure was normal. Gram stain culture normal. Meningitis panels, which we run here with a multiplex PCR assessment for 14 different pathogens, was negative. And early on, we were able to start performing some SARS-CoV-2 PCR testing in patients presenting with COVID-19, and that was negative. And again, these weren't validated tests. They needed to be done in-house validated. So we see, abnormal MRI, abnormal protein. With our ability to test these patients, based on our sedation protocol, we were able to take, selectively choose which patients we would take for advanced testing, because not all patients could get this testing. These early challenges, like I discussed, in safe patient transport. The MRI studies did identify in a series of cases, including JC, these covert diffusion restriction, kind of consistent with possible ischemic stroke. And the abnormal CSF, was quite puzzling initially, and not certain what to do with these. Are there high elevations in protein on a select number of cases, but no clear, pathognomonic, elevation in antibodies that were tested, or any PCR testing that was positive. And then my colleague, Eric Leota, who's also director of our transcranial Doppler lab, was able to kind of institute policies to keep the machine and technicians safe. And he himself actually did some of these studies directly. And we were able to start performing transcranial Doppler assessments of patients in this state. And interestingly, we found a series of patients who would have a high intensity signals or hits suggesting of this coagulopathy. So here in the right lower corner are kind of just representative images and something we have published looking at presence of transcranial Doppler hits in these patients and possible association with coagulopathy in the development of covert stroke. So I have to pause again for a second and think about, so what was the most frequent neurologic symptom or syndrome that was identified in hospitalized COVID-19 patients? And please take a moment to take your guess. Was it anosmia, headache, seizure, stroke, or encephalopathy? Give you a few seconds to jump in. Just take your best guess. All right, I think, Adam, that's probably enough time to share whoever preliminarily has answered already. Okay, a wide range. We have anosmia, headache, and encephalopathy being the leading causes. Seizure, very low, interesting, and stroke. We can talk more about this. So, interestingly, in the symptoms that developed or they were identified in the hospital, the most frequent was, in fact, encephalopathy. And this work was highlighted not only by our own work, but some work recreated across even with the GCS-COVID consortium that Dr. Chou helps lead, that encephalopathy rates were, as high as 30 to 60% in these patients. And again, whether they present with encephalopathy or develop it as a consequence of their critical illness, I think is a lot still being teased out there. So, JC's course, he was hospitalized for over 6 weeks. He required a tracheostomy and a gastrostomy tube to be placed, really for a bridge to his neurologic recovery. And it was great to see that he did actually have a dramatic improvement in his neurologic status. He was awake, interactive, and no cranial nerve abnormalities were identified. He had marked proximal weakness, which was actually quite common in some of these patients, not surprising to many of us critical care providers with the development of critical illness, myopathy, and polyneuropathy, given the prolonged courses in the hospital. He was discharged to what's called a long-term acute care facility, which is kind of a bridge from an inpatient hospital setting here in the US, but subsequently was able to go to inpatient acute rehabilitation. He's functionally independent now, and he was actually seen in our multidisciplinary COVID-19 clinic, which was developed early in May of 2020 and followed up specifically in our NeuroCOVID clinic. But JC, just like a subset of others that were identified, did have persistent neurologic symptoms after COVID-19, and his main symptoms were this brain fog, this subjective term that I feel has become very common and difficult to tease apart. So, what do we do with these post-COVID symptoms and syndromes? And we've seen a lot of media and news on long COVID. And there was a recent science review published by Serena Spudik and Avi Nath at the NIH that I think really captured it quite well. And, so there's generalized neuroinflammation. This can happen in the setting of not only COVID-19, but other severe illness, sepsis, and our immune cells kind of interact with the brain and cerebral vasculature in a unique way. What we do know is that there's limited presence on postmortem studies and pathologic studies of the SARS-CoV-2 protein actually in the brain or in neurons or other cells in postmortem analysis. There is an increased recognition of blood vessels that have been damaged. The endothelial cells are capable of being infected, and this can lead to microinfarcts, hemorrhages. We've seen some of that in our own cases. And then the antibody production that results from SARS-CoV-2 autoantibodies. There have been limited case reports looking at an autoimmune kind of encephalitis picture that's been presented by our colleagues at UCSF and Mike Wilson's group. But really, this susceptibility that while some patients more susceptible for genetic reasons, and what causes the mechanisms of these neurologic injury in a select subset of patients who are suffering from long COVID syndrome really remains to be determined. And I think there will be a lot of work in this over the coming years because of the just vast number of patients impacted. So some of our own work, and happy to share some of my own work with our group, is we've identified patients with neurologic dysfunction, with impaired cognition, unstructured, NIH toolbox and cognitive testing. Serial MRI scans performed in some of these patients. I show you in panel A, we see kind of non-specific white matter abnormalities and otherwise healthy individuals previously, or evidence of kind of susceptibility weighted sequences in, the splenium, deep basal ganglia, these microhemorrhages. And, this has been identified in COVID, but there's also been reports of this in, in severe sepsis and other diseases. So what's related specific to COVID and what's not? And then, some work I'm excited to share is, isolation of blood mononuclear cells from some of these long COVID patients shows that there is evidence of true immune dysfunction. And this graph here on the right, kind of looking at PBMCs that are isolated, and we see that in an assay of transendothelial migration, that there's a subset of these patients that have, abnormal migration, where their peripheral blood mononuclear cells actually migrate at a different rate or irregularly compared to healthy controls. So I think there's a lot of work to be done in the area of long COVID and assessing critically ill patients and the consequences of the immune system on their neurologic function. But hopefully I've been able to show you kind of the relevance for neurologic and critical care, kind of combining and assessing the commonalities and needs for long-term outcomes in patients with COVID-19. So I'm going to cut that short here, and I just want to acknowledge the large group of people that kind of went into this team of work. On the left here, a lot of our COVID providers and NeuroCOVID team. I wanted to thank Eric Liotta, my colleague, who really was there with me side by side, kind of evaluating some of these patients early on and developing protocols. Igor Korelnik and his collaboration with the outpatient NeuroCOVID clinic team. Sherry Chou for her guidance and leadership at the GCS-COVID Consortium. Our team of medical students and research assistants who really, we could not have done this without our colleagues in the medical intensive care unit, psychiatry, pharmacy, and then Bill Muller, Dave Sullivan, some of my laboratory colleagues in pathology who I work very closely with in some of the preliminary data, and of course, Farzaneh Suran, my mentoring, Dimitri Kramsuk, my chair, who've been very supportive of this work. And at this time, I think we can take questions or go to other aspects of our forum. And thank you again for letting me share this with you all today.
Thank you, Dr. Batra. That was a fantastic presentation and a swift tour through all of these sort of critically ill patients we saw and continue to see throughout the pandemic. Welcome everyone, and for anyone who's joined us, please feel free to share your thoughts and your comments and questions with us through the chat or through raising your hand. And I see there's already a question in the chat. So Dr. Batra, are there studies whereby the pathogenesis of SARS-CoV-2 have been investigated regarding the glands in the head, such as the pineal?
Thank you for that question. That's very interesting. To date, I haven't seen anything specific related to pineal gland involvement or direct infection. As I presented earlier, the direct neural invasion of SARS-CoV-2 the data has been fairly limited. Part of the challenges that we've learned in the past 2 years with the vast amount of rapidly disseminated knowledge is conflicting reports, and how we as clinicians and clinician scientists, what do we do with conflicting reports? And so I think we kind of wait for consensus and see what's plausible and what's not. So, while I have not seen myself any direct studies looking at the pineal gland, there certainly are studies looking at, disruption of the circadian rhythm and how, critical illness can impact the circadian rhythm and how disruption of the circadian rhythm can lead to worsening outcomes. So I think there is probably an overlap there where the pineal gland is certainly involved indirectly, but I think that may apply more to its role in regulation of the circadian rhythm and critical illness and less to the direct viral invasion of the pineal.
And thank you, Glo, for that question. And another one from Samantha. How many patients got a cognitive communication disorder post-COVID? Have PCDH19 epilepsy gene. I'm not sure I don't know what that is, but Dr. Batra, can you perhaps talk about sort of a post-COVID cognitive and communication issues?
Yeah, and I think that has really been the humbling nature of evaluating these patients with critical illness in the hospital, and where neurologists really need to be involved, is we've seen a pretty high incidence of post-COVID, severe COVID cognitive impairment, and how that's evaluated and seen really looks at structured tool assessments. Now, of course, many of these patients didn't have a baseline cognitive assessment to begin with prior, And so subsequently, there is some confounding, but patients subjectively are not able to return to jobs and things that they were able to do prior to their severe illness. So I think there is validity, and we look at population-controlled norms. I do want to mention that while we've seen this incidence in COVID-19, this has also been around with severe sepsis. And I think, underrepresented in the literature perhaps is severe sepsis can also cause cognitive impairment. And the incidence of severe sepsis and cognitive impairment, I think if anything, through the COVID-19 pandemic, we've learned that the impact of critical illness on the brain is quite severe and not necessarily just specific to COVID, but also other diseases. So perhaps this will spark more interests and prospective studies across the critical care fields to also look at cognitive impairment after severe critical illness.
And I think Professor Michael has a question.
Yes.
Thanks, Dr. Batra. That was really great. Gave us a great perspective of the ITU elements of COVID. Now, we are all by our temperament and heuristics, lumpers or splitters. I just wondered, given your experience and you're reading the literature, because there was that large individual patient data meta-analysis that came out in PLOS One last week, where they were able to show that much of the early data from countries like where I am in the UK and in the US was actually recapitulated, where in fact encephalopathy was the most common neurological complication in 40 other countries, including low and middle income settings. In that context, if it's 50% of hospitalized patients with a neurological complication have encephalopathy, to what extent do you think there's merit in distinguishing encephalopathy with or without seizures from an encephalopathy in the context of a stroke on imaging and clinical signs, to the context of delirium, where there's very clear systemic perturbations, but the brain itself may be structurally not that abnormal? Or do you think there is merit in this term neuro-COVID, which I hear a lot, but I wonder, is there neuro-COVID, or are there a spectrum of neurological complications of COVID? Just interested.
No, I appreciate that's a great question. And I would actually tend to personally agree more with the latter, but I think that there's a spectrum of neurologic complications from COVID. NeuroCOVID is helpful for grouping a large group of syndromes together, and if that's what it takes to get more people engaged and interested, I think it's very useful from that perspective. But as a splitter and identifying known neurologic diseases, I think what we're seeing is that there is a lot of encephalopathy in these patients, and then because of our limited testing that we would do in traditional settings, we weren't able to identify patients who may have had covert stroke, and we weren't able to necessarily always identify some patients who had non-convulsive seizures. Depending on the literature you look at, the incidence of non-convulsive seizures we reported reasonably high in some patients, and we already know that in critical illness there is at least a 10 to 14% chance of non-convulsive seizures in that population in and of itself. So what I will say though, with one caveat, is that the rates of encephalopathy with COVID-19 were particularly unique, where we had a number of patients who presented upfront as delirium and confusion as their early symptom. And I think that is potentially unique to COVID and SARS-CoV-2. So that could be teased out further, but I think overall, as a large group of neuro-COVID symptoms, I think there are buckets that we're going to continue to tease out and categorize with more detail as we learn more.
And I see a hand raised. Dr. Drummond, did I say your name correctly?
Hello, good afternoon. I am Zainab Drame. I'm not a doctor yet.
Welcome.
But I work for the Medical Research Council at LSHTM as a scientific officer, and I'm volunteering with Peace of Mind Gambia. Actually, my question is going to be kind of linked to what Professor Benedict Michael has asked about, because I was going to ask about something similar, because we can see that, for example, patients with conditions such as dementia, some of them already have encephalopathy, as in the form of brain atrophies in the brain via CT scans. And this can be detected via CT scans. So I was wondering, did this look at prior history of patients? I think you mentioned something like that, Dr. Batra, but especially for some of us that come from low and middle income countries, most of these patients, the history might not have been presented. and then maybe later cognitive impairments and delirium and all of these things, but the symptoms might have been more evident later on post-COVID. But especially my focus here really is on those who might have been asymptomatic in the COVID disease when they contacted it. How then would someone from a low and middle income background be able to assess this to the best, so that to give best care to these patients?
Yeah, no, I think that's a very important point, and I think the practical relevance is, like, across the board. If the medical history is limited, or maybe there was some pre-existing condition that wasn't necessarily diagnosed, that's one confounder. But yeah, in otherwise healthy individuals who present with severe COVID or hospitalized and then post-COVID, what can be done for them, for those patients? And I think first and foremost, we just need I would say a consistent way to evaluate these patients post-hospitalization, and kind of harmonization of basic things that we would be looking for. And I think the WHO has done a really great effort to try to harmonize some of the data elements to evaluate for post-COVID. And I think, for those patients, a reasonable thing to do is, just being evaluated in their traditional general practitioner's office or clinical office, and standardized, in the public domain available cognitive testing that can be done. I think just keeping track of that, independent of any advanced imaging or advanced, testing, and tracking that over time, that in and of itself may have utility, and at least substratify those patients who seem to be performing much worse than others, and at least in identifying a patient population that would benefit from some intervention. And what that intervention may be, I think there's a lot of literature looking on vitamin supplementation, cognitive behavioral rehabilitation, treatment of anxiety and depression. What those ultimate treatments will be, I don't know, but the first and foremost approach is just tracking those patients and identifying these phenotypes. I hope that gets to your question. I see another one in the chat that I just wanted to comment on because it's something that's very interesting to me. So it looks like Rahul Aurora said that, so I'll read it out. Neurologic dysfunction from COVID has been compared to consequences of chemotherapy on the brain due to its effects on microglia. Are there any measures to mitigate the effects of this infection, and have vaccines been found to be preventative in this role? So that's a great point. It's actually very near and dear to my heart, is given my interests in inflammation and inflammation-mediated brain dysfunction. There's a paper by our colleagues, Michelle Mangian group out in Stanford, who looked at this post-chemotherapy brain, and they're looking at CSF markers of what happens, elevations in specific cytokines, and the ratio of those cytokines kind of as a marker of post-cognitive dysfunction after chemotherapy. And a subset of COVID patients with neurologic symptoms post-COVID seem to have a similar type of cytokine pattern or array. So one, I think it identifies that there is some overlaps in the immune-mediated mechanisms of this cognitive dysfunction, and whether it can be induced iatrogenically through drugs and therapies, or if it can be, as a result of a host response to a disease. But, as far as mitigating these effects, I think that's where the data is much more limited. And have vaccines been found to be preventative in the role? As far as I know, I'm not aware of that. I don't know if anybody else on our panel is aware of the vaccine role in preventing this mitigation and potential microglial dysfunction. It seems plausible, but myself, I'm just not aware of that literature yet.
So if I can jump in and perhaps help a little bit with that one.
Yes.
Yes, in countries where we've seen very good vaccine rollout programs, we've seen a concomitant reduction in the rates of people hospitalized with severe encephalopathy as a percentage of those hospitalized, not just a reduction in hospitalizations. But to what extent that's changes in variants, and also changes in therapeutics as well. There's some exciting work coming out in JAMA Neurology, I think, in a couple of months. So I'll trail that one without saying too much. But yeah, watch this space. Thanks.
That's fantastic. We'll look for that publication with bated breath. There are many other questions that have come through. So Inette has asked, what neuroprotective treatments are known at this time in connection with dampening the inflammatory response? Should patients without respiratory distress get steroids, while steroids also have negative effects on the brain?
Thank you, Annette, for that question. So, as far as the data we have at the moment, it appears in, the New England Journal of Medicine paper looking at dexamethasone treatment for patients with COVID-19, at least based on that data, and that's the robust data I can cite at the moment, patients without respiratory distress should, at least for now, not be getting steroids empirically for COVID-19, with the caveat that, there are probably unique patients that may benefit from it depending on their specific, premorbid conditions. If they have, inflammatory lung disease or asthma or COPD, then most certainly they should probably get steroids in the absence of the respiratory symptoms presenting. But yes, and then we also know that there can be a harmful effect of steroids long-term on the brain. But rather than steroids itself, we are so fortunate to be in an age where medical advancements and treatments that have, tailored out the immune therapies, that we can be much more targeted than just steroids and specific, monoclonal antibodies or specific targets against, interleukins, IL-1 beta receptor antagonists. Our armament for immune treatments has really improved. And there are other acute inflammatory neurologic diseases where we've shown that treatments with tailored immunotherapy can work and prevent injury. Now, whether that will be, common or identified for post-COVID encephalopathy or post-sepsis encephalopathy, I think that remains to be determined. But yeah, I think that's a great question. And in terms of neuroprotective treatments, I think that's what we're all striving for, and why, as a neurointensivist, I'm interested, because that's when they're presenting, and early in the course, if we can identify and treat them then we can prevent the injury to begin with.
Yeah, I fully agree with you, Ayush. And, this question just, reminds me of all the other times when we try to neuroprotect our critically ill patients, and steroid has seemed like such a great idea for many other pathologies until we tried them in these multi-center trials, and somehow it rarely delivered the effect that we were looking for. But hopefully we'll be able to find a more targeted therapy, as Professor Batra has mentioned. I have another question from Dr. Susana Pena. Has any variant of the virus been identified with more neurotropism, neuroinvasion, or more virulence?
That's a great question, a concerning question, of course, but a very relevant question. I know that there have been, variants identified that can evade vaccination a little better than others. We've experienced some of those variants. But in terms of more frequent neuroinvasion, I haven't seen one, named or called out yet to date. And I looked at this great panel here to see if anybody else can comment on that as well. But is that plausible? I mean, certainly could be, but at least as far as I know, there hasn't been one specifically identified yet.
I see. Ben, do you have a comment on that? And
it was only just, yeah, I was just to help close out that last question a little bit as well. So I don't think we know really well. I think you're right, but perhaps we know that some of the variants are less immunogenic, and it's that element of the brain complication, as you mentioned, rather than neurotropism per se, which is the important difference in the variants. Thanks.
And I think, Viraj, you have your hand raised.
Yes, thanks. Thank you very much for the talk, Dr. Batra. Just as Ben mentioned earlier, there's lumpers and splitters, and I think I might be a lumper. So obviously post-viral syndromes have been known about for a long time. Is there anything sort of quantitatively or qualitatively different about long COVID as compared to many of the other post-viral syndromes? You have to do a neurology clinic for a while to see lots of patients with sort of post-viral fatigue, post-viral brain fog. Is there anything about long COVID that we think is different to any of that?
That's a great point, and I'll qualify it both ways. So at least in many of our lifetimes, we have never seen a viral post-syndrome with this prevalence, right? So the sheer number of people impacted. So with that caveat, we see a lot of cases of much more post-viral syndrome. Now, what is unique about SARS-CoV-2 compared to other potential viruses, and going to that, that recent review I was presenting at the end, that ability for SARS-CoV-2 to impact endothelial cells to cause this vascular injury, I think that's what makes it a little more unique than many other traditional viruses, influenza, things like that, where you can certainly have complications such as stroke and coagulopathy and severe cases of influenza. But I think the unique role of SARS-CoV-2 with endothelial involvement and this immune thrombosis that can take place, I think that may play a bigger role in the long COVID, at least from the neurologic perspective, the neurologic consequences of COVID in terms of cognitive impairment. We see the data on looking at CT scan, changes in brain size and atrophy, and those could all be linked by covert strokes, microemboli, things like that. So our own work, again, I'm biased. We've seen some of that ourselves. So I don't know if that answers it completely. I think there is a unique subset of SARS-CoV-2 that makes it a little different from traditional post-viral syndromes. But again, we've never seen post-viral syndromes with this incidence before in our life, in many of our lifetimes.
Sure. Thank you. Thanks very much.
Yeah, I was just, if I may, just to second Dr. Batra's comment and to address the $1 million question that Viraj had asked. I think personally, it's always been, to me, it was challenging, especially during the early part of the pandemic, to separate out the impacts of severe and critical illness, prolonged and severe critical illness that we see in this pandemic from other things that we had seen in the past with influenza or other types of viruses, and to understand to what extent those weeks and months of critical illness and shock and ARDS play into the subsequent encephalopathy and the neurological changes that we see. And, as an intensivist, I'm grateful to say that it, with over the last 2 years, we've seen so much has changed that this disease now is turned into much more of from a primarily ICU disease is turned into more of an outpatient, milder form of disease. And maybe now we actually would have an opportunity for the first time to really understand how it affects patients neurologically and cognitively in someone who didn't have to go through those extraordinary measures that we put people through in the intensive care unit. Because that experience alone comes with its own set of confounders and neurological impacts. But without going on further, I see Nicoline has her hand raised, and please, Nicoline.
Yeah, I just wanted to weigh in on all of the many comments that have come up today about the residual cognitive impairment and how do we distinguish this from a post-ICU syndrome, or how do we assess the severity and the sort of the integrity of that cognitive impairment. And so I just wanted to share with the group that I've posted several links into the chat as resources for people who might be interested in that topic, and to let people know that as the WHO, we collaborated with a group of experts in order to try and define exactly what constitutes post-COVID syndrome or long COVID, of which cognitive impairment is a large part of that. And so we have finished the what portion of it. So what do we measure when we're studying long COVID? And currently we are in the middle of a Delphi survey to try and determine the best instruments to measure that. And I would encourage anybody here who has post-COVID or who treats patients with post-COVID, or as a family member or even a researcher or a clinician, to please go to that site, the research site, which I've posted in the chat, and to, if you are within one of the categories of people who's able to fill out the survey, to please weigh in and be a part of that, because this is the second portion of that. And anybody who has experience with this, we would love to hear you and hear your feedback as part of this survey. Thank you.
It keeps striking me, just thinking back to the case you presented today, Ayush, that this was a 37-year-old, otherwise highly, we may not call him healthy, but he was at the prime of his life and probably didn't ever need to see a doctor until this all hit him. And we presented the case in a span of 15 minutes, but if we look back in the timeline, what you described, that whole experience was weeks in an acute care hospital under very intensive care, followed by long-term hospitalization, followed by rehabilitation. The impact on this person's life and everybody around him is unimaginable. And I think to many extent, all of our other COVID patients, and even if they didn't have to get admitted to the ICU, the impact on their lives and the prolonged symptoms has been incredible. And you know, how we best study that and measure that. And I know, Ben, you've been doing leading a huge amount of work on this, and you know, the WHO and Nicolene, you know, collecting this large group of experts, many of whom are in the audience, to try to come up with these ways to capture and measure and understand what the syndrome is, and in different parts of the world as well. Your thoughts on that, Ben?
No, that's great, super. I mean, this has been a really robust discussion from coming at it from all sorts of different angles. So it's been really great, and it highlights how far we've come and how far we have to go yet. But there's a great team. I just wanted to very briefly close with just a couple of things. A lot's been raised about the complexities of encephalopathy in COVID-19. And an international consensus guidance for the diagnosis and management of encephalopathy in COVID-19 has been published by myself, but also by Professor Sherry Chou and many others who were all brought together because of Nicolene's team in the WHO. People who'd never worked together from very different fields. I'm not neurocritical care, for example, from many different countries, including our colleagues in low and middle income settings. And I posted the link in the chat if you'd like to read a bit more about it. I guess it's just to say thanks for so many people joining us from all over the world for sharing their wonderful experiences and all their comments and questions. I'll let Professor Chou close, but just lastly to say, if you enjoyed this and you're interested in hearing more, do please join us for our next one on July the 22nd, which will be led by Professor Andrea Winkler from Germany and Professor Fan Ki Hu from Malaysia, talking about One Health and how human health and animal health and the environment are all interlinked. Thank you all for coming. Professor Chou, back to you.
Thank you so much, Professor Michael and Ben, dear Ben. And I think it's really just, I just want to comment on what a wonderful experience it is to share this session with so many people from all over the globe, really, and to hear everybody's comments and perspectives. And it's such an honor for myself, and I want to particularly thank Dr. Batra for his wonderful presentation for us today. And it's an honor to be able to participate in this. I've participated as a speaker and now as a chair, and many times as an audience. And this is something not to be missed, and such a unique and incredibly important contribution. So thank you for that. And Dr. Batra, any closing words?
No, thank you so much. Thank you to Ben, Dr. Chou, Nicolene, the WHO. I think this has been a really great discussion. I'm really grateful to have a chance to participate. I look forward to attending more of these sessions in the future. And I really want to thank our audience today for the really thoughtful discussion, the personal stories, and the coming together from all different angles and all different sides. We can really try to address this in a way that can benefit the most of our populations. So thank you again.